to our palliative and end-of-life seminars over the next 3 days. We're absolutely delighted to have you all with us and really looking forward to an interactive and wonderful discussion on this very important topic. I'd like to start just with a quote from Dame Cicely Saunders, the founder of the hospice movement. You matter because you are you, and you matter to the end of your life. And I think that's a great way for us to think about our talks today and to listen to the many experts that we've got. So welcome to everybody, both presenting and attending our palliative and end-of-life seminar, Navigating the Services, over the next 3 days. We've been absolutely delighted by the interest in this important conversation and are absolutely thrilled that our distinguished speakers are giving their time to share their expertise this week. We hope that each day brings you all a shared understanding of palliative and end-of-life care, the opportunity for collaboration and a conversation that helps to develop an enriched insight into acute services, planning and keeping well in the community. Each person will get some information following the event, speaker contact details, PowerPoints, CPD certificates and links to YouTube for the recordings. Firstly, and I know that everyone is kindly already doing this, can I ask that all delegates mute themselves and turn off their cameras unless they're presenting, and remind people that by joining the meeting they've agreed to us recording it and sharing it. There will be a bar showing that this is when the recording is beginning. To ask a question, can you please put that in the chat box? We will use the raise the hand button on the taskbar as well. By just clicking on the 3 dots, but we may well have over 100 people joining. So what we're going to do is use the chat box as much as possible. I'll select a couple of questions, but all the answers to all the questions will be circulated after the event. We do have some social media and we'd love to be trending. So please use the hashtag, which is hashtag EEOL and capital C for Cornwall. And the capital E is importantly, apparently, because we may need to mention the hashtag a few times. There may be some problems with those viewing seeing the presenter because we are in meeting mode rather than as a live event. So to have the whole page view, you can pin a speaker by hovering over their name at the bottom left. And if you right click on the 3 dots, you can also have the option of pinning or unpinning. Speakers will be in full screen mode automatically, we think, when they share their screen to show a PowerPoint or PDF. So fingers crossed, everyone's got one. Lolly is going to be doing her best with production throughout the meeting and will also keep me in control along with Tracy in terms of the presentations and the timings. Lolly's also looking at the chat box questions and we'll send some specific cherry pick ones that we think are most appropriate to the conversation at the time. Every question is welcome. Please be open with all your thoughts. We will pick everything up afterwards. Our day 3 will run slightly differently as speakers do not have the same opportunity to talk about their organisation. It will be an open debate, which will be via responding to attendees' questions. And Lolly will feed those questions from the main chat to me. So I will make sure that all of that is flowing. If you are attending across all 3, day 3 is just going to be a very different experience. And then at the end of the conference, we've also got Gina, who's going to be joining us just to give her overview of the whole thing and to talk about our next event, which is going to be in May during Dying Matters Week, and also to talk about our community services newsletter, which is going to be coming out later in the spring. So you've heard enough from me, and now I want to hand over to our first speaker, and that is Dr. Carolyn Campbell.
Thank you very much, Nikki. I'm Carolyn. I'm one of the consultants in palliative medicine in Cornwall and am based at Cornwall Hospice Care. But as a small consultant team, we work across all settings in Cornwall with all of the teams, and so also work supporting our community teams and hospital team. And I'm talking about 2 things today which link in with each other. The first is our hospice advice line service, which is often the first contact a lot of people have with us. And then a bit about actually who comes to the hospice, what patients do we have in our physical hospice beds? And those link up because obviously patients come to us through referrals and the advice line is part of that process. And then I will hand back to Nikki, and then we're going on to Louise, who's our ward sister in one of our hospice units, to talk in a bit more detail about what it's like to come in. So I'm going to share my slides now, hopefully successfully. I don't know what that noise is. It's not coming from me. Can I just double check that those slides are visible?
Yes, Carolyn.
Yeah, they're fine. Lovely. Okay. So,
you might want
to. Sorry?
No, that's great.
Great. The Specialist Palliative Care Advice Line is something very, very close to my heart because I was involved with setting it up in the first place quite a while ago, really quite a while ago in 2009. And at that point, there wasn't any one place in Cornwall to go for specialist palliative care advice. And so sometimes people would phone a specific colleague that they knew, perhaps in the hospital or in the hospice, or they'd phone a community nurse. And if they couldn't get that person, it was then difficult to know where to go next. And so at that stage, it was a fairly modest aim of having one number that we could give people to call so that they could get advice more easily. And that first year, we took 236 calls over the year. We've just had audit data back from the last year, and I was fairly staggered to see that rather neatly in 10 years, our calls have increased tenfold, and we had over 2,000 calls last year. Despite that extraordinary increase in that time, the fundamentals of how the advice line works on the ground haven't changed a great deal. Calls come into our hospice unit in Hale, St Julia's Hospice, and are picked up by our admin staff, nurses and doctors. And at the back of that advice line, there is a consultant on call 24 hours a day, 7 days a week. And most of the calls, probably about 60% plus, come to us as consultants in the end. But a lot of them can be dealt with by other members of the team. And that service, as well as offering advice to healthcare professionals throughout Cornwall, supports the specialist palliative care nursing teams in their settings. So as I've said, we're quite a small consultant team and are limited in where we can be at any one time. So the advice line has meant that for those teams, they can get hold of us more easily and always get hold of someone. And it provides the only on-call palliative care support at night and over much of the weekend to all settings in Cornwall. Despite the fact it's a fairly resource light in terms of number of people service, we respond to 50% of calls within 15 minutes and 80% within 60 minutes. And our administrators or the nurses at night, when they take the call, always find out whether the call is desperately urgent. Is this someone who's in a patient's house and needs an answer right now? Or is it something that can wait a little bit? So with those urgent calls, we try and get back very fast. And it wouldn't be much of a talk on the advice line if I didn't put the number on it. So the number is there. If you didn't have it already, write it down. So what I've done, I've got lots of numbers about the advice line and we've been running it for 10 years. We've been monitoring and auditing it and analysing it all the way through that time. But I thought it would be a bit dry just to go through the numbers. So what I want to do is try and give you a bit of a picture of who calls us, why, and what that actually achieves. So I've broken down the numbers a little bit. Probably the commonest reason we have for people calling us is, how can I help my patient? As I've said, the advice line is there for all healthcare professionals in Cornwall. So we get calls from GPs, from primary care nurses in the community, from paramedics, from doctors and nurses in the hospital, and from our specialist palliative care colleagues. We get calls from care homes. We've sometimes had calls from pharmacists. So the advice line is there for all healthcare professionals. It's not there at the moment as a direct number for patients and relatives. That's something that would be lovely to have, but which needs a very different resource sitting behind it. So most people are calling us because they have a patient who's having... Sorry, can someone mute their microphone? Someone's not on mute, thanks. Most people call us because they have a patient who's having a difficult time. And so these are all anonymised real patients, the examples I've put in here. This was a GP up near Wadebridge who phoned me, having tried lots of things with a lady who was having a terrible time with nausea and vomiting. He'd worked his way through the BNF trying different antiemetics and nothing seemed to be working. And this lady was just desperate not to go into hospital or hospice. She didn't want to go anywhere else. So what we were able to do over the phone was do some unpicking of what the likely causes of her nausea was and look at not only different medications, but different ways of giving them, because she'd got into a very difficult vicious cycle where she wasn't absorbing the medication she was being given. And actually a short period of having those medications by injection with the district nurses helped to settle things down. And we managed to keep her at home as planned. So that's the core of what the advice line's there for, those symptom control calls. And we get called about every symptom under the sun and then some. The other main block of calls is those relating to admissions. So does this patient need to come in? And I'm going to talk a bit more in the second part of the talk about the patients who do come into us. Up to 40% of the calls, that is initially part of the question, is should this patient be coming into the hospice? But actually only half of those are a straightforward, this person needs to come in now. And those are relatively straightforward calls to deal with. That's often GPs perhaps out of hours with a patient who's been struggling at home and things have reached a crisis and they need to come in. Where an admission's agreed, we get 81% of those patients in within 24 hours. And what we're now getting better and better at doing as we integrate services is where we can't get a patient in straight away because we don't have a bed, working with the teams we're talking to identify the right place for someone. Because sometimes a patient really needs to go in, but the challenge is getting them to the right place first time, because as we all know, it's really, really hard for people to go into one place and then be moved repeatedly. So this is a call I took a couple of months ago, a gentleman with prostate cancer whose pain was getting worse, struggling, now couldn't walk and had had an episode of incontinence, and his wife was really struggling with looking after him and had no help at home. And actually the discussion I then had with the GP was really important in terms of getting more information. At first sight, this is a gentleman who's got difficult symptoms. He's got pain that's not controlled. And it might seem that the hospice was absolutely the right place. However, what we were trying to unpick in that conversation was, is there something going on here like spinal cord compression that actually needs urgent oncology attention? And if so, what's the best way of getting that? Could he go in directly under the oncologists, or would he be better coming to the hospice and then going for a scan? In a slightly different circumstance, if the issues were mainly around mobility, continence and care, what we now have in Cornwall, which is a fantastic development over the last year, is direct acute admissions to some of our community hospitals in what are called CATUs, Community Assessment and Treatment Units, where patients can go in for rapid multidisciplinary assessment. So a key part of those initial discussions is working out where does this patient need to go so that we get them to the right place first time rather than putting people through multiple moves. The third really key bit of the advice line is supporting our specialist teams. We have absolutely fantastic specialist nursing teams working in the hospitals and in the community, and they are the backbone, eyes, ears and hands of palliative care for the vast majority of patients in the county. And one of the things that has developed as the advice line has run is the best way for us as consultants to support those teams when they need us. Because as with any other team, we outrageously have holiday and occasionally get ill and move around. So what we now have is a consultant of the day system, where not only out of hours is there someone on call, but one consultant holds all of that acute work each day so that they can respond quickly to requests for help and coordinate that information, pull it together. And that's been a key part of us working as a more integrated virtual team across all settings in Cornwall. The really helpful development this year is that we've now linked that. Someone's again got an unmuted microphone, sorry. Could everyone check they're muted? We've now linked that into integrated multidisciplinary team meetings each week, where as well as the own teams MDTs where they discuss their complex patients, we have crossover MDTs which allow hospice community and hospital to talk to each other about complex patients who might be moving between sites. And that's made a huge difference in, again, trying to get particularly very complex patients to the right place and getting the right treatment in a timely way. And this was a key thing with an incredibly complex patient I discussed with, well, several of us discussed with colleagues in the East team some weeks ago, who not only had several cancers, but was on dialysis and had inflammatory bowel disease. He was discussed at MDT, his problems then became more severe, and there were questions over whether or not he was reaching a point of his disease where he wanted to stop dialysis, but needed some urgent investigations. So we arranged for him to go into Tralis to have those investigations, liaised with the hospital team while he was in there, and then actually when he reached a point where he did choose to stop dialysis and was coming towards the end of his life, he then chose to come to one of the hospices so that he and his wife could be supported at that point. And that was an incredibly complex situation, but because of that integrated working and that system where the information was held together, we were able to support all of those teams to provide care to that patient as if we were a single team in a single place. And so often when someone's coming to us saying, I'm not sure where to go next with this patient, our role is to be able to offer things that may not have been thought of, which might be reviewing that patient jointly, which paradoxically has become almost easier this year since we're all getting used to doing that virtually. Seeing the patient in our pain clinic, which we run jointly with the pain physicians, or bringing them in. And perhaps most importantly, we're here when people need to say help. And I think this is for the thing that for me is most satisfying with the advice line, because people are dealing with complex situations in very difficult circumstances this year, perhaps more than ever. And having the advice line there in that situation can make a huge difference. So we're here for junior doctors who are on nights, perhaps with senior support, very busy elsewhere, dealing with a dying patient for perhaps the first time and not sure what to do. We're here for care homes and for paramedics who may be dealing with a patient with limited resources and limited experience in doing that, and may have drugs written up, but may need that bit of support to know which drug to give and to talk them through that. It's been particularly poignant, I think, this year, to be supporting our amazing respiratory and ITU teams as they've dealt with deaths from a disease none of us had seen before. And actually those calls in turn have led to updating and changing of guidance to support those teams better. And we sometimes have quite Cornwall specific cries for help. So it's really important to understand local issues when we're dealing with perhaps an out-of-hours GP managing a patient in a remote area where there are no pharmacies for 30 miles and most of those are shut, to help them actually work out what the best way is to manage that patient with the medication and the resources that they've got. So where next for the advice line? I hope it's clear after that the need for it isn't in any doubt. But certainly we need to keep looking, as we have done throughout its 10-year life, at how it works and how we can improve it. A really key bit that over this last couple of years has been increasing the integration of the services, and that will go on being key. But we're also hoping to look at the levels of activity, how we make it more effective, and perhaps some formal commissioning to sit behind that. We have excellent urgent care services in Cornwall, and it may be that more integration with those would improve flexibility and responsiveness. And our bugbear always in healthcare is different IT systems in different settings. So we're always looking at ways we can integrate those better. And a key development that's coming with that over the next year or so is Coordinate My Care, which is a new system that will enable us to share information about patients' wishes and advanced decisions, treatment escalation plans, and so on between providers at different times. So I'm going to pause there if that's, well, no, I think probably, Nikki, if we do questions at the end, is that all right? And I'll keep going for now.
Yes, please. That'd be great.
Okay, so I'll keep going. So I'm going to jump on to hospice inpatient care, and the most sensible, I know this will be very familiar to some of you, but less so to others, and that's the joy of a conference like this. We have such a broad range of people here. So I thought I would stick to basics: where, who, why, when, what, and how. So this is a wonderful quote that someone said to me when I very first moved to Cornwall many years ago. If you were designing a county for healthcare, you wouldn't make it this shape. Cornwall is a fantastic shape for beach holidays, but quite awkward to provide healthcare in because it's long and thin, has no motorways, and lots of lovely windy roads. And in the summer, lots and lots of people on those windy roads. So we get around that because we're very adaptable. I always have to apologise for this map because it left the Isles of Scilly off, and they're a very important part of our community. So you just have to imagine them on there because we do cover them too. So we have 2 hospices in Cornwall. One is in St Austell and one in Hale. It looks like it's in Penzance there, but that's just because the names moved. So that, as you can already see, spaces us out so that most patients in Cornwall are within a 40 to 45 minute drive of one of the hospices. And that balances quite well with our advice line, which obviously covers the whole county, and our 2 acute hospitals in Truro and Penzance. And we then are incredibly lucky in having a wealth of community hospitals throughout the county. I do apologise, I haven't updated this diagram, and I think there are sadly 2 community hospitals on there that are no longer there. And then most importantly, joining all of those up are our fantastic community teams, both our specialist palliative care team and our incredible primary care service. So although it may be an awkwardly shaped county, we love it and we managed to cover it remarkably well. This is Mount Edgecombe Hospice, our entrance. We still have lots of patients and relatives and some healthcare colleagues who are very anxious about coming to the hospice and who think it will be somewhere dark and dingy and gloomy and depressing. People normally get a surprise if they think that when they come to hospices, because they tend to be light and bright and remarkably cheerful places. We have video tours of both of the hospices on our website, and they're well worth a look. We actually put them on there pre-COVID, but they've become even more useful since then as they enable people to have a walk around. So who do we take? Essentially, adults with any chronic progressive disease who need to come. The majority of our patients still have cancer, but we are not in any way limited by diagnosis, and we see more and more patients with non-cancer diagnoses. So patients with chronic respiratory disease, COPD and pulmonary fibrosis, patients with renal or hepatic failure, lots of patients with progressive neurological disorders like motor neuron disease, and increasingly, as we all live longer, complex patients who have multiple problems which interact with each other. One project I'm particularly proud to have been involved with over the last year has been looking at how we open up our services more to people who have in the past struggled to access hospice services. So people who may be homeless or vulnerably housed or may have substance or alcohol dependencies. And we're working really closely with partners to look at how we make our services more accessible to everyone in Cornwall. The key thing is we're happy to discuss any case. Sometimes we won't be the right place for a patient, and we'll be very open about that, but we can offer outreach support to patients in other settings as well. So examples of that are that our hospices are designed to give patients quite a lot of privacy and quiet. That means that they're they're not particularly open plan. They're not like a ward where a nurse sitting at a station can see most patients from there. And so sometimes they're not the right place for someone who's very confused and wandering, because actually there are lots of outside doors and there can be safety issues. We do manage patients with dementia and with delirium, but we'll always look at whether actually it's the right place for a patient or whether they would be better in their own setting within reach from us. We work closely with specialist units like Marie-Therese House, so their very specialist skills may be better than ours for some patients with, for example, multiple sclerosis. But that's always an individual decision. And just going back to that statement about referrals at the top, we are registered as an adult hospice, but we work closely and flexibly with our colleagues in the children's hospice and the paediatric service to look after patients in the right place for them. And so I think someone from the Children's Hospice is speaking later on, so I won't overlap too much, but we can sometimes flex slightly on age from both the children's and adult hospices so that, again, we're looking after people in the right place for that individual. So why do people come into us? Very simply because they're having a difficult time. And that may be with physical symptoms, it may be with psychological adaptation to their disease. It's very often with a mixture. People always think of hospices as being about dying, and some people do come to us specifically because this is their preferred place to be at the end of their life. And some people come to us for symptom control, and actually things move more quickly than anticipated. But overall, around 50% of our patients go home again, and some patients have multiple admissions with us, sometimes over a period of years. So lots of calls start along the lines of, I'm not sure if this patient is right for you, and if in doubt, if that question's going through your mind, phone us, because we can talk that through and work that out together. So when is key, and this follows on, the patient comes to us when they need to come. There is still that lingering idea that hospices are only for the very end of life. We see some patients very early on in their disease because they're having a really difficult time with physical or psychological symptoms related to that. We then often see patients at points during their disease where they're having a difficult time with symptoms, struggling with treatment, having bad news about progression of disease. And then, of course, we see lots of people at the end of their lives. Our average length of stay is around 10 days to 2 weeks, but there's a huge range within that. And I wanted to use two short case vignettes just to illustrate how that can be very appropriate. So Leren was a young woman who was with us a few years ago with very horrible metastatic bowel cancer, and some really, really difficult symptoms as a result of both her disease itself and of the treatment. And she in the end was with us for over 2 months because her symptoms were so complex. Her social and psychological issues were also very complex. And actually the whole time she was in with us, she was needing constant adjustment of medications, a huge amount of psychosocial support from both her and her family, and the situation changed constantly. So that was a very long admission. That was absolutely extreme, but there is nowhere else that she could have been and had that level of attention except the acute hospital, which wouldn't have been an appropriate environment for her for that length of time. Eva is a patient I admitted very, very recently, who came into us as a planned admission, who was a lady with motor neuron disease who was dependent on her non-invasive ventilator and had reached a point where that was causing her more problems than it was helping and making her quality of life very poor. And she chose to come into us at the end of her life to stop using the ventilator in a supported, comfortable place where she felt safe and knew her symptoms would be controlled. And she was actually only with us in the end for less than a day. But that was, again, the right thing for her and her family, to be somewhere they could be supported and safe and comfortable through that very difficult time of knowing that she was in the last hours of her life. So our range is huge. And I always, at this point, bring up a patient who came to us, I think, at every single one of those points. So if you have a little time, go to the hospice website and look at the video of George's story. George came to us over 10 years, and he came to us from those very early stages of coming to terms with his diagnosis of metastatic prostate cancer through many relapses and recoveries. I think he saw every member of our multidisciplinary team, and then we were very privileged to have him with us at the end of his life. And I don't think any of us will ever forget him. So the crux of all of that is what we provide, which is specialist multidisciplinary holistic care. And we have a full specialist team in the hospices. We work jointly with other teams. And that means that we're able to bring all of those resources together to try and get things right for these very complex patients. Because of that, we're not a long-term care setting, because we need to use those resources as effectively as possible for the most people who can benefit from it. So we always specify to people when we come in that once things are stable, we will be looking to get them home again or to another place of care. And that's another lovely quote from the husband of one of our patients. And very, very important thing, we always facilitate pets visiting. I think we've had in my time here, not only dogs, but cats, parrots, a snake, and once a horse who walked around the outside and put his head in the window.
Carolyn, your presentation isn't showing at the moment, so I just wondered if you wouldn't mind just resharing your screen.
Yes, of course. Which slide do you want? Well,
the
slides are going to people.
Yeah, last couple.
I don't know why that is. It jumped briefly. The
joy of technology.
Absolutely. I think what I have to do is unshare it and reshare it. I think someone else may have accidentally screen shared for a moment, which may have jumped it. There we go. Is that it showing again?
That is, yeah, brilliant.
Lovely. No one wants to talk about COVID at the moment, but I'm only going to touch on it briefly just to explain to you what we've done over the last year with COVID. So we've worked with all of our healthcare partners and colleagues in Cornwall to be part of the whole system-wide response to COVID. And they asked us to remain as green, or ideally COVID-free beds, so that there would be a safe place in Cornwall for our very vulnerable patient group to be looked after, with as little worry about catching COVID in that context as possible. We obviously can't, nowhere can guarantee to stay COVID free, but we have been remarkably successful in that over the last year. We've been very committed to supporting our colleagues in all settings, and that means that at times we've widened our referral criteria to free up beds in the Acute Trust, and worked very closely with our community colleagues to try and get people to the right place at the right time. We're very lucky from an infection control point of view. We have all single rooms at St Julia's and very large 4-bedded bays, as well as single rooms at Mount Edgecombe. So what we've done is run those bays with only 2 patients in them so that we can keep people very safe. We've been supported in our turn with excellent access to testing throughout. And that means that we've been able to allow visitors throughout, which has been very important, that we've had to limit numbers and times more than we normally would. And we're now delighted to be able to offer lateral flow testing to regular visitors to help them protect their loved ones better. And like all healthcare settings, we've supported people to use video calls much more. So the last question very quickly is how, which is very simple because it goes back to the number I gave you at the beginning of the talk. If you think you have a patient who might benefit from coming to the hospice or might benefit from our outpatient services, you phone us and we will talk through with you. We made the very conscious decision when we set the advice line up not to have a written referral form. Every patient is different, and we have always found the most useful thing is to talk through with you what your patient needs and what the right thing is for them. So I'm going to unshare my screen now so that I can see you all again, or at least see the list of people, and would be very happy to answer any questions I can.
Thanks so much, Carolyn, and absolutely love that you don't have a referral form when it's a conversation.
I get filling in, so I'm always very anti. We fill it in once we've got your information.
Makes a real difference. So there's a couple of questions, one from Steve Hawkins. Carolyn, do we have any idea of the unmet need which might be helped by the advice line, and what are we doing to try to ensure that as many people in Cornwall who should know about it do?
It's unmet needs a really hard thing to measure. We're measuring it better than we used to. So we moved our technology on a bit, so we now know if we fail to answer a call, and we've now put in an answer phone system so that if we can't get to the phone, you can leave a message and we'll get back to you very quickly. In terms of what's much harder to measure is people not phoning it, and we know that there is unmet need there, and our biggest concern is particularly around care homes, where we know they are doing an amazing job of looking after, especially over this last year, looking after many patients with huge needs. So we're working with the Cornwall End of Life Strategy Group to look at how we get information about the advice line and our services into more care homes and give those staff the confidence to call us. We're fairly happy that most GPs and primary care staff know. We talk about it in induction every year with new junior doctors in the trust, but we're very aware there's unmet need that we really want to meet.
Thank you. I'm just wondering, how do you look at integrating this service and thinking about the unmet need into education services, like health and social care workers and new nurses coming through the system before they actually get into the workplace?
That's a really great thought. We work on it. We're really glad now to have lots of students actually physically come through the hospices, and our staff talk to nursing and medical, OT, physio students. So we, compared to when I was a student, there is much more discussion earlier on, and hopefully that raises a lot of awareness. And we would always be delighted to come and talk to groups of students. So we're trying to get in there much earlier. And we're really pleased that actually throughout COVID, we've still had students coming to the hospices, because although that's sometimes difficult to manage, we need to keep training our doctors, nurses, physios, OTs of the future. And it's a huge benefit to both us and them to have them here.
Yeah, absolutely. A question from Rachel Burden, just saying that she's concerned that there's enough advanced care planning being done. So just be great to get your view on that, and then how it feeds into all of the points you've been raising in terms of when people come in, how people are prepared. So yeah, kind of just your thoughts on that would be great.
I think it is one of the most important things, and it's something that we're constantly again working on and thinking about. We've done a lot of work with our oncology colleagues, and I'm not going to jump ahead of Mike, who's going to talk about the enhanced supportive care service, but I think of the places I've worked, Cornwall is probably one of the best I've encountered in supporting patients with cancer, to think early about what they want and don't want, and to be aware that palliative care and oncology services can work together. It's not one or the other. I actually had a meeting yesterday with one of our hepatology colleagues who's really keen to do advanced care planning with more of his liver failure patients. And we're really hoping to build with our colleagues in hepatology, renal care, respiratory care, to do more advanced care planning. I think for all the awfulnesses of this last year, perhaps one benefit is that it has encouraged people to think more about advanced care planning, and to think about what they want for themselves, to talk perhaps within their families about what they want. And that's, I hope we can build on that in better times to help people to make those decisions, because as I say, there isn't one right answer. And for us, the most important thing is to do what's right for each individual patient. We can't do that if we don't know what they think.
Yeah, thank you. And Rachel's come back to say that she agrees that not enough is really being done to support care homes. Often those patients are the most unwell and dependent. Rarely are TEPs in place or advanced care planning to discuss wishes at the end of life. So I guess added to that, just to in terms of the emerging themes from COVID and your experience over the last year, and the potential that this is going to be with us, ongoing in some form or another, how do you see that informing the work that's underway, and also just the reaching out to the public, perhaps through social prescribers and other of those community-facing roles that can really help to enhance the understanding of what's available and why these tools like advanced care planning are important?
I think that's so vital. And we'd started to do some of that work. Lolly's done some fantastic work with death cafes and with outreach in the community. But I think Rachel's absolutely right. I think this year has brought home to many people. I think lots of us in healthcare were already very aware of the enormous work that goes on in care homes to look after the most vulnerable people, and how under-resourced and under-connected those services are to the NHS. And I think for us, we desperately want to build on that, and we want to build on that clinically in terms of building those links, but also in terms of education, in terms of outreach, in terms of talking to care homes, not just about what we think they need from us, but what they think they need from us, so that we can actually work properly as partners. And I think probably the biggest positive I can see from the last year is that the joint working in Cornwall has been better than I have ever seen it since I first came down here as a medical student. I'm not going to say how many years ago, quite a lot of years ago. There has been more joined up working, and I really, really hope we can build on that and move that even further in the future.
Wonderful, thank you. I mean, what an inspiring presentation, and thank you so much for your time. I think it raises so many, in fact, there's some comments that are coming through just in terms of the opportunity to hear you and to understand that there is an advice line that people, even if they're not working, can ring and get advice. And that kind of safe port of call, which is often what people need, isn't it, at some of those most difficult times, whether you're having to make a decision or whether it's you're actually supporting a family member. So thank you so much for that presentation, really appreciate it. I've just got something else from Jane Burnell, which is some care settings believe that CQC insist on end-of-life care planning for every resident. This is not true. Advanced care planning is important. How can we assure it is centred on the individual, their personal and health needs? So I'll take that as one last question so I don't overrun into Louise's presentation.
Sure. I think it's a huge challenge, Jane, and I think the key bit with that is joint working between the care home, the GP and the primary care nursing team to help have those individualised discussions with every resident, ideally when they first come into residential care, but also at key points where something changes. So it might be that someone who's been in care for a while has a hospital admission or an acute event that changes what they think and want. And that we need to build a system where that acts as a trigger each time to say, this is what you thought you wanted before, but actually, is there anything you want to change there? Is there anything we should do differently? And we're there to support that service, but actually we're not on the ground with you in that same way. So I think that joint working between primary care and care homes is the key there.
Great, thank you so much, Carolyn. Really, really appreciate it, and hope if you've got time you can stay around for a little while.
I will definitely stay, but thank you so much for inviting me. I've really enjoyed talking to you.
Thank you.
Thanks,
and now,
thanks, Carolyn. Nikki, I'm just going to mute everybody and then let you unmute because we're having some microphone issues. Is that all right?
No problem.
So bear with me. Okay, ready? Okay.
Great, thank you. So now we're going to hear from Louise Ranford, who's the ward sister at St Julia's Hospice.
Great, thanks Nikki, and thanks Carolyn for a great presentation. Hopefully mine will kind of flow through now to a day one admission at the hospice. And yeah, I've got a short presentation to show you guys, so I'll just see if I can get that up. I hope that I don't cover too many topics that Carolyn's already talked about, but yeah, okay. So yeah, as I said, I'm Louise, the ward sister at St Julia's, and there's obviously the other hospice at Mount Edgecombe based in St Austell, which is Sally Davies is the ward sister. So I'm going to predominantly talk about St Julia's just because this is obviously my unit. So that's a lovely picture of our hospice. And yeah, so both units are currently running at 10 beds for inpatients. At St Julia's, we've got, they're all individual rooms. So they've got en suites as well, and they've got double doors that open out onto the gardens, where you've got like an individual kind of garden area where family and friends would normally obviously gather pre-COVID times.
Lou, can I just interrupt, Lou? You might want to put it on slideshow because people are having difficulties. Is that all right?
Is it not?
That might be better now. Yep.
Is that all right? I've not.
Yeah, if you go back one, let's just see. Perfect. Thank you. Sorry to interrupt.
Yeah. Can I just check with you, Lolly? So the one you're seeing now is
Louise Ranford, Cornwall Hospice Care logo. Everyone's saying it's fab. It's working now. So yeah. Sorry.
And the one now you can see. Yeah. So that's the hospice with the sunset. Brilliant. Lovely. Okay. So yeah, as I was saying, that's our hospice, and we've got the 10 rooms that are single rooms with en suites, and the doors that open up into the gardens. And obviously we specialise in symptom control and end of life care. So hopefully now you can see a picture of one of our lovely volunteers. I just better say that the pictures were all taken kind of pre-COVID days, so no one's wearing masks and PPE. But it gives you a nice view of, friendly faces there. So yeah, prior to COVID, we actually employed about 900 volunteers through Cornwall Hospice Care. Obviously, they've been limited now, especially on the inpatient unit. This so what we have here is on reception. The guys will man reception all day long and meet and greet people that are coming in and family members and direct you to anywhere that you may need to go for outpatients as well. We have the volunteers that are on the ward. They help with delivering meals, talking to the family and friends, patients, and also pre-COVID days, they would do a lot of all of our flowers and upkeep of that side. Then on to our nursing staff. We have an average of about 40 members of the nursing team. So that's from trained nurses and healthcares. And we've also got Siobhan, which is our advanced nurse practitioner, which is quite a new role. And she works really closely between the nursing and doctors, and is also working out into the community with seeing patients either pre-admission or being able to go out and actually use her expertise alongside the community team to make sure that patient's getting what they need, and if their wish is to stay at home, there's that kind of link still to the hospice and the hospice team. So yeah, we specialise in palliative care, and through our education team as well, we've had lots of end-of-life training and advanced care planning that we're putting into practice. We also support nursing students and nurse associate students that are also coming through, and we've also got our staff that are engaging with that and actually going out as well to the hospital and into the community and being part of that nurse associate training. So then we've got our medical staff team, and that's from the doctors, so the consultants. We've got the middle grades, and we've got GP trainees that come on rotation, and we're working with the medical students as well, so they're experiencing that part of their career. And then we've also got our patient and family support services, which is down here, it's Marie, and the other end is a lady, Ange. So they're actually supporting patients and family on the inpatient unit, but then also following up with bereavement support. And our therapy team, so the ones that are kind of based on the inpatient unit is our physiotherapist and our occupational therapist. So they'll obviously work for mobility purposes, getting you kind of to the level that you would like to be at, and for preparation for going home. And then also the occupational therapist Chloe will work very closely with you and your family for looking at equipment and, you know, exercises to help with symptoms as well on the inpatient unit. We've got a very dedicated housekeeping team that keep this place absolutely spick and span, including the staff. Yeah, they work, you know, tirelessly, making sure we've got our beds turning over, our rooms are cleaned in a timely manner, ready for the next admission. And they often, you know, really engage with the patients and family as well. And there's often really more positive feedback about the time that they get to spend talking with the patient and families, and, you know, going through bits. And then our catering team, so they go above and beyond to make sure anyone's nutritional needs met. Often we know there's, you know, it might just be the smallest thing that they're really fancying, and they'll make sure they go out their way to find that meal that they may really crave. Or you know, we do have a set menu that they very loosely follow, but they'll also, you know, they'll always work with the patient, and the family also have the opportunity to have meals here. And we're very lucky as staff that they will cater for us as well. And then our admin team that also work really tirelessly behind the scenes, just making sure everything's running really smoothly with all the administrative side of things. So yeah, our admissions and how we manage these. So obviously, as Carolyn had recently just spoke about with the advice line, your calls will come through to there and speak to the consultant of the day, where they will then be in contact with the nursing team, and we do a brief overview in the morning, so they get a feel of exactly, you know, how many admissions we can take, how many discharges we have, and really plan then for admissions coming into the unit. So what to expect on your first day in the hospice. So as you come in the doors, you would be greeted by one of our volunteers, and then you would have one of our nursing members of staff come up and greet you as well, take you down to your room and get you comfortable and settled into the unit. Pre-COVID, obviously family members would definitely be encouraged to come through and be with you through the admission process. At the minute, we're saying with visiting that there's two key visitors you have, and only one person at the minute to be at the bedside at one time. So obviously we encourage them to be present as well if it's right for your admission. Obviously, you know, if you're here, then you're going to feel you've come in because you're needing the hospice and you're not feeling very well, you're tired, you're lethargic. So it's always, you know, helpful having that family member there to be able to talk through and answer some questions from that side of it. So then, yeah, we would have the doctors and nurses would come and spend some time with you and your family member, then discussing, you know, kind of the issues that would have brought you into the unit, what your goals are, and you know, what's really important to you and your family, and what you would really like to get out from the admission here. Also looking at like where you'd like to be cared for in the future. And obviously, if it was end of life care, then that would be discussed as well. So during your admission as well, just what to be expected of. So our daily routine obviously works around the patient. So if you're feeling, you know, your mornings aren't quite as good as your evenings, then we would prioritise that and make sure we spend, you know, let you have a rest in the morning, and then you know, reviews and talking through things in the afternoon. Obviously also trying to conserve energy for time with your family as well. We have a really, you know, MDT approach, so the multidisciplinary team. So every day we discuss in the morning with the physios, occupational therapists, the family liaison, nurse consultants, doctors and nurses, you know, how we're planning your care, that obviously you and your family members are kind of you're moving towards. We also have a weekly multidisciplinary team meeting, so that's another way of really getting everyone together and looking at your goals and make forward planning for them together. And then also with our discharge planning, you know, we tend to start that ball rolling actually from admission, as there's so many kind of, you know, paperwork and admin side of it as well, that we would never want to miss that opportunity to get you home if that's what you want to do for either a short period of time, long period of time. If we don't start that kind of planning early in that admission, then that could be missed. So yeah, just making sure we're on the discharge planning. And yeah, we have a home-to-home environment. So pre-COVID, you know, we would have every family member in, celebrate birthdays, and we've had weddings, and we've had weddings even in COVID times, garden parties and everything like that. So it's really making you feel comfortable and settled in this kind of home environment. Yeah, and then I've just signposted as well to the St Julia's Hospice tour down the bottom, but thank you for your time, and if you've got any questions, please fire away.
Well, thank you, Louise. That's fantastic. And, you know, there's comments coming through the chat box already. I had the privilege of seeing this firsthand 18 months ago when my father-in-law spent his final days in care. It was first-class care from volunteers right through to the senior consultants. And there's a question from Peter Long. What about the liaison between faith chaplains and clergy at home bases?
Yeah, so we did have someone based on site pre-COVID. However, now if the patient requests for someone to come in, we would obviously we definitely let them in. I can't say for home circumstances, but I can certainly find out.
Thank you. And Jane's just come back, and I guess just in terms of the hospice and people with learning disabilities, Louise, Jane's just saying that not all care settings are obviously that when they may be coming up from older people, and a typical small setting for adults with learning disabilities has a death perhaps every 5 years. So on the one hand, it's awful when end of life care planning happens too late or not at all. And on the other hand, think how it might sound to the parent of a fit person in their early 30s to be asked of end of life care planning. I suspect there are general things that should happen for everyone. What is important to this person? How do they show if they are distressed or in pain? And death is a part of life and should not be a taboo topic, but advanced care planning with people who do not have a life-limiting illness calls for a sensitive, personalised approach, and in some cases it might not be appropriate. So I suppose just to those points, how do you manage that from coming in on a ward perspective or working with people then that perhaps would also go out of the ward with learning disabilities?
Yeah, so I think we're you know, we've got a very wide range of skills from the team from that side of it as well, to meet those needs. And obviously we can work really closely with the patient as well as their loved ones and whoever may care for them in the community. So, you know, they would obviously know their needs as well. So we would 100% be wanting to get them involved as much as possible to make sure that we meet that patient's needs.
Wonderful, thank you. So Kylie has said from Cornwall Partnership Foundation, thank you for the support you offer to the community nursing teams. Whenever you need your advice from your team, you're always there to assist us by phone. And then another question from the Sabrina, do you offer the support of doulas as supplementary care?
Sorry, say that again.
Do you offer the support of doulas as supplementary care?
Not at the moment, no.
Okay, thank you. And is that something in terms of I'm just thinking about like on the go conversations, is it something that people could kind of perhaps get in touch to discuss?
Yeah, definitely. If there's a need for someone, we would obviously, you know, we would explore and we would do everything in our power to be able to get that. So we would do anything for anyone.
Yeah, fantastic, Louise. Thank you so much. I mean, the work you do is absolutely phenomenal.
No, thank you, and sorry about the nerves if they got the better of me.
No, not at all. Carolyn's also just popped up to say you work closely with learning disability support teams to help us care for patients and meet their needs, and it's always great to work jointly with them. So clearly a lot of support available, and you know, a very multidisciplinary team for people to access. So thank you once again. Really appreciate your time today.
Thank you.
So now we're going to hear from Elizabeth Thomas, and they're from Royal Cornwall Hospital, and she's a specialist in palliative from the palliative care team.
Hello everybody, and can you hear me okay?
Yeah, fine, thank you.
Lovely. Oh, thank you for asking me to speak today. So I'm Liz. I'm jointly practitioner of palliative end of life care team here at the Royal Cornwall Hospitals Trust. And it's lovely to be able to follow on from Louise, because I think it just shows how much our services overlap and how we work, work together. So here at the Royal Cornwall Hospital, obviously we recognise the importance of delivering excellent care, and we strive for that very much so. And it's obviously not only those that are receiving acute care, but those that are approaching end of life. So we're a small team based in a large hospital. We're an advisory service, and we work across 7 days, 8 until 4. So we're a team of 6 nurses, with 5 of us working clinically. 2 in the team are non-medical prescribers, which is a very handy skill to have when you're based in the acute setting, in that you can start changes and go back the next day and see the difference that's made to your patients. We work very closely with in-reach support from our palliative consultant body, who are supporting us currently via telephone advice, but obviously there is plans going forward that they will be have somebody based with us here in the hospital. So we see patients across the whole of the trust. There isn't really anywhere that we don't go now at any point in their disease trajectory, and that can be somebody who's just had a new diagnosis, to somebody who's coming with a treatment related condition, and it's those also that are in the last few days to hours of life. And we also see people that are having curative treatment, but they may have difficult symptoms. Often that group of patients are people that are undergoing chemo radiotherapy as an outpatient. Our particular group that we do get a lot of referrals for, the head and neck cancer patients who undergo very grueling schedules and develop an onset of very difficult symptoms. So we work with them for the duration of that treatment, and our aim is to try and prevent an admission by managing their symptoms. And we don't just see cancer patients, we see patients with non-malignant conditions such as end-stage heart failure, end-stage renal failure, motor neuron disease, and those numbers of the non-malignant disease group are gradually rising, which is good, and they're over 30% from our last year's annual figures. So our referral criteria, we deal with complex symptom management when the wards are struggling and they've made changes that are not working. We give psychological support to the patients and their families, staff. We help with complex discharges. We facilitate hospice transfers and look at advanced care planning, crisis management, and obviously looking at the patient very much as a whole. We have referral criteria and we ask for referrals to come through our maxings, but equally we get face-to-face on a ward. Somebody can call us, and we're always happy to support any ward team that may be struggling. We don't stick rigidly to our criteria. Anyone can refer. We ask for permission from the patient, ideally if the clinical team refer, but a relative can refer on behalf of their loved one that's in hospital, and sometimes patients ask to see us themselves, particularly if they're known to the community team. They just like to see someone, often just to join things up for them during their acute admission. Other things that we do is we provide training and opportunities for ongoing learning and development in palliative care for healthcare professionals, and obviously it's a large organisation. We now do mandatory training. My colleague does mandatory training for the trust, and there's all sorts of opportunities for education, which is a bit challenging at the current time, but we endeavour to provide that as we need to do it and what we're asked to do. So we very much look at that individualised approach to patient care, looking at the holistic needs of the patient and the family. Often we find in our role that we're dealing more with the family than we are the patient, because they can be struggling more with a certain situation. Each week we have an MDT on a Wednesday where we have representation from our occupational therapist, a physio, chaplaincy and ourselves, and we discuss the patient's holistic needs, looking at making sure that we're endeavouring to meet all of their needs. That could be financial, psychological. We may want to refer on to psychological support services. We need to put them in touch with benefits advisors. So we join that all up each week and try and make sure that we've got a proper plan and that it's joined up. We work with extended team members such as speech and language, dietitians. The Cove Cancer Centre obviously is working virtually at the moment, but that's another resource for our patients that they can just drop in when it's normally open to get advice on various things, particularly benefits and things which can be expedited for those that are often in a crisis. And I know certainly that they're linking in very closely with us at the moment, because I had a call yesterday from the counsellor who's been dealing with a patient that I've been seeing, and she's been ringing on the ward to support her. So it's still working well in these very challenging, times. So we work closely also with our community palliative care teams when patients are going from here across into a different setting. We now have sort of weekly cross-setting MDTs with the hospices and community palliative care, so we can let them know where the patient's in that they may know, or if somebody's transitioning out into the community. We also link very closely with the district nursing teams who do a lot of end-of-life care, GPs, etc., just to try and make that very smooth transition across settings. So for our patients that are approaching end of life in the last few days to hours, as we know, there is still a large amount of people that do die in the acute setting, and our approach is very much what is important to the patient, what is important to the family, take the medical side of it out and identify, what their needs and what's important to them. And often it's the small things that make a difference. So we're trying to employ, very much that approach and embed that, give staff permission to break the rules, obviously within reason, use alcohol for mouth care if that's what the patient wants. Pre-COVID, we had somebody that went to the beach, we paid for the ambulance, and obviously then they came back, but they had a lovely day. They died here 2 days later, but it's just facilitating people's wishes and just pushing things a little bit further if we can. We too have had weddings on the ward that have been arranged within 3 hours. We've managed to get the choir down and all sorts of things like that, which makes such a difference, not only to the patients and families, but the staff. And it's just bringing that back to the patient and family. During COVID, again, we found it very challenging, I think, particularly with visiting, because it's our automatic thing to say, let's get the family in, and we know how much that means to the patient, but also to the staff. And I think we've all struggled with that immensely, although we do understand that it's important. So we've got iPads for every ward and iPhones. So we try to manage virtual visiting. It's not quite the same, but it's something. And there's a Stay Connected service also in the trust where people can send messages and things into the patient experience team, and then they'll print them off and send them to the wards. So we're sort of doing our best in very challenging times, much as all of the other teams are, and trying just to support the wards as well during this very difficult time. And looking to the future, we're hoping to get end of life volunteers. There is a huge team of volunteers, but we're looking to get a very volunteer specifically for end of life patients, so that they can go and sit with people that are approaching end of life, those that haven't got families, or for those people that they don't always get a lot of visitors. So we're looking towards doing that, and just adding in those extra layers of support, and just carrying on with that individualized approach. Really, we don't work in isolation. We're one part of a very big team. We work closely with the clinicians that look after the patients here, and as closely as we can with our colleagues across settings. We're just sort of a cog in the part of a very big wheel, really. And I think, like everybody else, it's just making sure that all continues to grow and work smoothly across settings. So I think that's it from me. I think that's kind of the service in a nutshell. You can go on talking for a long time, but it's just trying to encapsulate it all, really.
Thank you so much, Elizabeth. I mean, what an amazing service. And I guess just listening to you, how complex all of that in terms of fitting all of that around a person is. Just a question really from me, in terms of talking about palliative care, do you think that people sometimes get confused about what that is? Often that kind of the use of terminology, and how we can kind of get a better understanding that it's actually a whole person holistic approach.
Yes, I think that's exactly right, and I think we work very hard to try and take the sort of the fear out of it, because often there is a fear associated with that word, and I think it's palliative and end of life care, but actually people associate the word palliative with someone that's dying. And when I see a patient, I always say who I am and the reason that the doctors have wanted me, so they know that I'm there for pet or whatever that might be. And I think we often have to, work quite hard to dispel that. And I think it does sometimes. People they don't want the referral because they think it's almost a mission that they're going to die soon. But it's very much not about that. And I think, there's evidence to suggest that early introduction to such services as ours has better patient outcomes for the future. So I think it is very much associated with that, and and you can see sort of people trying to screen your badge sometimes when you turn up. I don't have end of life on my badge, but I know a few years ago I went to AMU to see a lady that was admitted with a pneumonia. She did have a lung cancer and she wasn't dying, but when I got there she said, "Oh my God, they've sent you." And that must mean that's it. And I said, no, that's not why I'm here. And the next day she said, "Oh, I'm so sorry, I got upset." She said, "But I really thought they thought I was going to die." And once we'd explained what, once she'd sort of taken it all in, she was fine. But I think it does still instill fear into people. Yeah,
and just another question really, I just in terms of just taking on from what you've just said, how do you think through engaging through the community? I was thinking about things like around GP practices, you've also got the patient participation groups and other things in terms of being able to raise awareness of the service. How do you think we might be able to get kind of, I guess, that promotion, if you like, for one?
I think that's a very good question. I think it is important to get into those groups. This, on sort of rare occasions, we get asked to speak at support groups, from the CNSs here. We've done talks at the lung group and the metastatic breast cancer group, and they are great opportunities. And I always take the opportunity to explain what we do. And the lung cancer group were very fearful that we'd even been asked to go there. But once we'd explained everything, we said we're here to talk about breathlessness, and they were very reassured. But they've come away with a different knowledge of what we do and that it's not to be worried about. So I think the more we could get that message out there, I think, you're absolutely right. I think it would give people a different view of the service and what it is really, and not to be alarmed about it. There must be hopefully networking.
I think great too to hear about, and there's some comments coming through. Thanks, Liz. Brilliant account of your great service. Lovely to see your face, Debbie, and that's Deborah Ward. And there's some great links being shared also in the chat, which is lovely to see as well. Services people didn't know about relating to palliative care and end-of-life care planning for individuals with learning needs. So the PCPRD network and that's known. So that's absolutely great. And I was just to pick up on what you were talking about, having volunteers being able to come in and sit with people.
Yeah.
There's some great examples of best practice, isn't there? I was thinking about the Pathway for Homeless Health that also have particular people go and sit with people and help that care transition across different departments. And I suppose, how much do you think kind of that best practice sharing across the country can help inform how you take things forward?
I think it's in looking at setting up the volunteer service with the voluntary services here. We've networked with other trusts that do a similar thing. Everyone's gone about funding, etc., because that's always the key thing, isn't it? Is where do we get the money from? So I think we've looked at other examples. The Anne Robson Trust was one of them, and just to how it's helped us a lot. And we came somewhere in between as what we would do and how we would try and go about it. So we just put a business case in for a volunteer coordinator. So we just have to keep everything crossed. If not, it will be fundraising, I think. But it's much needed, and it is a model other trusts are using. So I think it will be great. But we did do some scoping out of what other teams are doing. Yeah. And if we'd had them, obviously volunteers, there's some restrictions at the moment, but if they are still operating in other trusts during COVID, as long as they're not shielded or anything. So I think it would have been, if we'd had that service now, it would have been amazing support to the wards, particularly at the moment.
Yeah.
It's something for the future. It's something that we hopefully in 6 months' time we'll be able to say that we've got that working here for us. So yeah.
Fantastic. And Rosie's just come in to say partnership with the end of life doulas would also support this work really well. So there again, I think perhaps a conversation for offline. So once again, from everybody on the call, thank you so much for all the amazing work you're doing. It's been absolutely great to hear about the service today, and also kind of what's developing over the next few months. So stay safe.
Thank you very much. Thank you.
Thank you. So now we're going to hear from Katrina MacDonald, who's the Medical Director at Little Harbour Children's Hospice South West.
Good afternoon, everyone. I'm hoping that you can see my slides on the screen now. I'm Dr. Katrina MacDonald, and I'm the Medical Director at Little Harbour Children's Hospice, and I'm going to spend the next few minutes giving you a bit of a taste of the service that we offer, and also talking about our referral process. So we are a charity, and this is Little Harbour, and this is one of the Children's Hospice Southwest hospices which are open in the Southwest. Little Harbour opened its doors to children and families in December 2011, and this is at Porthpeen, St Austell in Cornwall. And the other two hospices in the Southwest are Littlebridge House in North Devon and Charlton Farm, which is just south of Bristol. So who are the group of children and young people that we look after at Children's Hospice Southwest? Our referral criteria is that the young person must have a life-limiting condition. That means there's no reasonable hope of cure or from which the child will die, or a life-threatening condition. That's where curative treatment may be feasible but may fail. So we accept children whose life expectancy is limited and children who are unlikely to reach adulthood. We accept antenatal referrals, and we look after young people up to the age of 21 years. So when we have a referral of a young person over the age of 16 years, we may consider accepting them depending on their problems and needs, but it may be more appropriate that they access adult services. And certainly Carolyn has already mentioned that as well in her talk, and we in fact work very closely together just to see where is the right place for that young person. Over the age of 18 years, we would usually signpost to adult services, but again, there may have to be a conversation about where is the right place for that young person according to their needs. And it's important that the appropriate children are accepted to Children's Hospice South West, and this is really determined by their medical prognosis. So how are children and young people with a palliative care need identified? And what are the group of children with life-limiting and life-threatening conditions which limit life expectancy? Well, there are very core definitions of children's palliative care, including a classification criteria for life-limiting and life-threatening conditions, which was initially developed by ACT, which was the Association of Children's Palliative Care, which has in fact evolved into Together for Short Lives, which a lot of you might be familiar with, and also the Royal College of Paediatrics and Child Health. And this is an internationally recognised criteria, of which there are 4 groups. Group 1, where there's a chance of cure is feasible. Group 2, although premature death is inevitable, there are periods of normality. Group 3, which is progressive conditions where there's horrible, relentless deterioration. And Group 4, which is a group of children that have irreversible but non-progressive conditions, but whose prognosis may in many cases be very unpredictable. These groups are not without the limitations, and there's been a lot of work in children's palliative care developing better frameworks at looking at children's needs and prognostic implications. And these frameworks look at vulnerability factors. For example, children are in and out of hospital with repeated chest infections, repeated admissions to PICU, repeated hospital admissions, evolving gut problems. An example of this is the spectrum of children's palliative care, but there are a number of vulnerability factors that we also use. What do we offer? We also offer the holistic approach. So what does that mean? We're embracing physical, emotional, social and spiritual elements, focusing on the enhancement of the quality of life for the child and young person, and also support for the whole family from the point of diagnosis or the point of referral throughout the child's life and after death, and supporting the family with bereavement. Now, traditionally, pre-COVID, our offer was the provision of short breaks, as well as end-of-life care, symptom control stays, and bereavement support. The short breaks were that each child was offered a number of days per year to stay with their family or without their family at the hospice. The short breaks were never a replacement for respite provided by statutory providers. It was in addition to the statutory respite. Sadly, the COVID pandemic has meant that we are not able to offer short breaks at the moment, but we've introduced a different sort of stay called a resilient stay, where we are supporting families who are struggling. It might be they're struggling because of illness in the family and they're not able to look after their children. It might be because of care packages breaking down and families just ending up exhausted, which has happened on a number of occasions. It might be there's equipment failure and the child just can't be safely looked after in the home. But new ways of working during the COVID pandemic has had some positive aspects, believe it or not, on our service development and what we are able to offer. And we've, as an organisation, we've been able to look at what we provide and to think what the children and our families need. And we've been doing a lot more outreach work and providing community care shifts and support visits. Sometimes it's just a doorstop visit, just to offer families support and just say, we know you're here, what can we help you with? And sometimes it might be collecting prescriptions, it might be running errands, but whatever we can do to help families to get them through coping with COVID. These visits have been extremely successful, and I think they'll certainly carry on when hopefully in the future the COVID will be more under control. We have an amazing sibling support team as well, because often the siblings don't get as much attention and into their well-being and their needs because the families are so busy. We've also been offering day visits, a lot of success with children coming in for jacuzzis, music therapy. And also, as a lot of us have found out, Zoom has just got very big everywhere. And we also been doing a lot of bedtime Zoom stories for children and families, bingo, and dial in and have a cup of tea and chat sessions. So who are the team? There's me, the medical director, and there's a number of sessional doctors who come in and provide support. These are a mixture of GPs and paediatricians. We have the amazing nurses who are children's nurses, as well as adult and learning disability nurses. We have a range of carers. We also have a physio. We have a music therapist. And it's certainly amazing to see how children who have complex needs respond to music therapy and stories and sensory, anything sensory. We have our sibling team, and we also have a social worker. So the process, what is the referral process? Anyone can make a referral for a child or young person. However, we do say the child must be resident within the Southwest, and we encourage referrals to the nearest hospice within the geographical location. We must have consent from families to proceed with a referral, and following the consent from families, we then write to healthcare professionals for medical information. The child must have a palliative care need to be accepted. And so we, when we write to healthcare professionals, we also mention vulnerability factors and also the surprise question as well. We use a lot. Would you be surprised if this child died before they reached adulthood? But clearly this can often be quite difficult to ask and for professionals to be able to say. So sometimes we back it up with a home visit to just make an assessment to see if a child meets our criteria. We have a weekly referral meeting where we discuss all the referrals. And each year we review each child's case and we check that they still meet our criteria, because you can imagine for children, some children may improve and be doing much better and remain well. And if that is the case, which is really good news, then we would start a deferral process. For further information, please do look at our website, and I've also included our email address and our phone number. With the COVID restrictions, we have not been able to have as many professionals visiting as in the past. We used to do a lot of tours for professionals to have a look round. We're lucky because of our zoning that when families are in, we are able to have visitors and important people. We're the same as the adult hospice as well. We have a lot of animals that come to visit the children while they're here as well. Thank you very much.
Thank you very much.
Thank you very much, Katrina.
What an incredibly amazing service to provide in very difficult circumstances. One of the questions in the chat that I was just going to ask you, I'm sorry, I'm running over a little bit on time, so I'll ask one. I'll just kind of raise this with you, and then Lolly's also put a link in the chat box. The support to children who are struggling with bereavement.
Yes, that's something certainly our sibling team provide a lot of support when the families have left the hospice. And we, pre-COVID, the sibling team actually did a lot of face-to-face group meetings with children of appropriate ages, children grouped into appropriate ages, just exploring bereavement and coming to terms with the loss. When we have children dying in house, we have again a lot of involvement and support for siblings, looking at exploring what they understand and just giving them the opportunity to cope with the situation, the really, really hard situation that they find themselves in.
Great, thank you ever so much. Really, really appreciate it. Just because Wendy may have to dash off, we're going to move on to the next presentation. So if there's anything else there for Katrina, please put it in the chat box. Lots of conversation and talk in the chat box about Cornwall Bereavement Network, Winston's Trust that also help with children and bereavement, and Penhaligon's Friends. So we just move now on to Wendy, who is the secondary breast cancer clinical nurse specialist at Royal Cornwall Hospital.
Here we go. Sorry, I can't turn my camera on. Good afternoon, everybody, and thank you for inviting me along this afternoon. And I've really enjoyed networking with the speakers that have gone before me. So I'd like to talk about secondary breast cancer, which is also referred to as metastatic breast cancer or advanced stage 4 cancer. This occurs when breast cancer cells spread from the primary tumour in the breast go through the lymphatic system or the blood system to other parts of the body. The most common parts of the body that I was reading the notes there. The most common sites for metastases are the bone, liver, the lungs, and the brain. Metastatic breast cancer is incurable, but patients with subtypes of secondary breast cancer can have their cancer managed for several years, and the treatment goal is palliation with the aim of maintaining and improving quality of life. So I'd like to talk about who this service is for. The secondary breast cancer service at the Royal Cornwall Hospitals Trust, the referral criteria and the team. So the service is aimed at patients with secondary or metastatic breast cancer, but we also look after patients with other stages of breast cancer when the cancer is inoperable, which therefore is incurable disease. And the aim of treatment, as I've said before, is to control the cancer and maintain quality of life. I'm sorry, I haven't got any slides. I'm just talking. I don't know if you can see me okay, but
yeah, we can see you.
Yeah, we can see
lovely.
you.
So the background to the service, I set the service up 6 years ago now. Before that, the breast care nurses, the breast care team are based in the Mermaid Centre and primarily a surgical pathway. So when patients were diagnosed with metastatic breast cancer, their care comes under oncology, and they didn't have a key worker, and it was seen as an unmet need, and a business case was put forward for this post. Throughout the UK, there are probably now 60 or 70 nurses in the same role. When I started, there were only about 14. Definitely Breast Cancer Now, which is a charity, two breast cancer charities merged, Breast Cancer Care and Breast Cancer Now. They've been going to Parliament and petitioning to improve the care for women with and men with secondary breast cancer. So the business case looked at how many patients were living in Cornwall with secondary breast cancer, and we weren't keeping a record because patients weren't being registered. So there were about 500 new breast cancers diagnosed a year, and there are about 100 patients a year diagnosed with secondary breast cancer, and currently about 300 patients in Cornwall living with secondary breast cancer. So my role is to support the patients from the point of diagnosis, echoes some of the other services really, coordinating investigations and procedures, and that can start from the very beginning, because when a patient's diagnosed, their cancer may have changed from their primary diagnosis. So gold standard is to try and get a biopsy if that's safe to do so. And in about 15% of cases, that histology has changed. So we want to make sure that the patients are on the right treatment. So our role is to move things along, make sure things are happening in a timely manner so that we can get those results and get that patient started on their treatment. So we provide information as well, so education about treatments, about their cancer as they want it. Not everybody wants information all at once, so it's as we're going along providing information and education. And also about support. So we work very closely with a lot of the services we've heard from already. So work very closely with the hospital palliative care team, sometimes doing joint visits. The community palliative care teams, definitely. I've spoken to a couple from the community teams today, and the hospice have been invaluable at supporting our patients. Sometimes as outpatient appointments at the hospice, the neighbourhood hubs, which I don't know if are going to be discussed at some point over the next couple of days.
Yes, they are.
And definitely during COVID, because our patients have, everybody, nobody can go say they haven't struggled during the coronavirus pandemic, me included. But the patients, when they've got not very long to live, and they're all of their bucket list goals, everything that they want to do, and so it's having somebody to talk to and trying to, if possible, having somebody they can see and talk to virtually. It's just a different world we're in at the moment, really. But hopefully it's getting better with the vaccines. A lot of my patients are telling me they're having the vaccine, which is great. The other part of our role, we heard about holistic needs quite a lot today as well, and we do like to assess patients' holistic needs. It's not mandatory, but actually patients do get a lot from that. They recognise things they didn't know were worrying them, really. Often a lot of our patients have children, so it's how do they talk to the children, making sure that the schools are aware of what's going on, support with finances. Do they need to be linked to palliative care? I mean, we're in the national guidelines for secondary breast cancer, it says we should do an early referral to palliative care, but some patients present with no symptoms at all, so actually it's not the right time for them. But just to introduce the services, know what's available, and as has been mentioned earlier, the palliative care, that's a really big hurdle for some patients to get over, understanding that actually it can be about supporting their symptoms, supporting their emotions, and their family members as well, which is really important. I think there's a gap there really there's a gap, I think, for children, pre-bereavement support for children. And I think there's also a gap for support for carers, for husbands and wives and partners of people living with metastatic disease. So that's something I was looking at in the future, possibly some kind of group, whether it's a generic group that we as CNSs can link into for carers, or whether specific for husbands and partners of women, men or women with secondary breast cancer, because they don't like to talk to their husbands and wives about how they're feeling, because they want to be strong for them, and it's just linking in for some support for them with somebody who's going through the same thing. We also, as specialist nurses, provide telephone support for patients, and we work from office hours 9 to 5 Monday to Friday, and patients will leave us messages at 9 or 10 at night or at a weekend, but they know that we'll pick it up when we come into work. This can involve symptom management, arranging procedures to avoid hospital admissions. So it's symptom management and advice for other healthcare professionals, both in primary and secondary care. We work closely with, I've already said, community palliative care nurses and district nurses. Absolutely value all of their input with our patients, and such great people out there, really. We also support the breast clinics in oncology. So we review patients alongside doctors, but also independently. And we aren't going to the wards at the moment, but we would go on ward rounds with our consultants and review inpatients, which is much more difficult now because we're reviewing patients over the telephone or advising doctors. This morning, I'm speaking to a doctor on one of the wards, giving some advice about a lady. And then we also every morning run a telephone medication and blood monitoring review clinic, and that helps to avoid patients having to come up to hospital. They can have a blood test with their GP, and we can monitor their bloods and let them know if they can start taking their anti-cancer treatments, and they really value that as well. So move on to our referral criteria. I don't know how easy you have access to Maxims in the community, but I think some of the GP surgeries have it. And so we have an inpatient electronic referral on Maxims. We're happy to share our telephone number, and we have a joint email, which is we're happy to share if there's any concerns about our patients or any advice that we can give anybody. We'd like to improve our relationships with the community at all times. And like Liz was saying earlier, sometimes it's a face-to-face referral. It's all of those ways. And the team, so I started off working on my own. I was on my own for about 3 years, no cross cover. The breast care nurses, bless them, did give me a bit of cross cover when I was on holiday if I was sick. I was on a course. I did do my prescribing course, which has been invaluable. And 3 years ago, we put a business case together then, and I've got another full-time equivalent specialist nurse, which some of you may well know, called Louise. She used to work in the community as a palliative care nurse, so I'm so lucky to have her in my team. We also have 3, I think they're probably part-time cancer support workers, and they are really helpful. They help to coordinate sending out. We do Macmillan electronic holistic needs assessments, which if patients would like an electronic form of the assessment, they'll send those out to the patient, or the paper versions, and then they liaise really closely with us. And when times were different, we'd meet at the Cove in one of the rooms sometimes just to talk to our patients and their relatives, going through their concerns and their holistic needs. So another great part of the team, and just recently a few very invaluable admin hours, which we're hoping will be extended at some point, because there are some things that we definitely can pass on to other to admin, very clever admin people to help us with our database and other things. So I think that's all I've got on my chat to you today. If there's any questions, I'd welcome them.
Thank you, Wendy.
Thank you for listening to me.
No, thank you, and you know, people putting in the chat, Helen, Trevelyan, you and your team do a fantastic job, Wendy.
Oh, that's nice, thank you.
Gwendolyn Trezida said the neighbourhood hubs also support carers, and we are considering groups, so maybe she could link up with you, Wendy.
Yeah, I love that.
Helen's come back to say good idea, Gwendolyn, and Siobhan has said fantastic, Wendy, can't wait to meet you in person.
Oh yeah.
I just want a final thought from me, listening to you, is also just about how we could perhaps link in through primary care, Wendy, through anticipatory care. When you're talking about preparing bereavement, so along with Lolly, looking at those groups and thinking about how we also might work with the social prescribers that could then provide that support at primary care. So again, we can pick all of this up offline with you just to see how we can help support you.
Yeah, lovely.
Help also, you know, to think about other ideas and take forward all the amazing work that you're doing in the way that you would want to. So Lolly has also said, thanks, that's great, Wendy. Yes, let's do more linking up.
Yeah, I'd love to. Yeah, thank you very much for inviting me.
No, it's thank you so much for everything you are doing, and we really appreciate your time today. Thank you.
Thank you. Thank you. Cheers.
And now we're going to hear from Mike Thomas, who's the lead enhanced supportive care clinical nurse specialist.
Bear with me, everybody. I'm just going to get my presentation up, I hope. Otherwise, I'll come back to you, Lolly.
Yeah, I can share if that's easier, Mike.
It's all right. I should be okay. Bear with. Bear with, bear with. Just coming up now. Let me know if you can see that, please, somebody.
Yeah, that's perfect.
Okay, thank you. Lovely, lovely. Well, hello, everybody, and it's nice to be here presenting this afternoon with the rest of the speakers. It's been really interesting, and I hope you're gaining the benefit from it. For those of you who don't know me, I've been around not quite as long as Florence, but almost. She was my cousin, but we won't talk about Florence. My background is from the field of palliative care. And if I go to my first slide, it does tell you, I'm not going to go through it. Suffice to say that I've been around quite a long time. I started my training initially in 1975, and now I'm back to lead the enhanced supportive care team. So literally from the pyramids. The actual initiative for enhanced supportive care came from Christie's Cancer Centre in Manchester back in 2015, but it was in 2016 that they set up the initial pilot site along with other hospitals throughout the country, Exeter being one of them. Basically, they recognized that there was a care gap provision for those who were newly diagnosed with a non-curative cancer. So if you were diagnosed with cancer, if it was a curative, fantastic, you had a lot of support from the site-specific nurses, etc., and you went through your chemo, radiation, or whatever. If it wasn't a curative, cancer, but it was a palliative intent for treatment or otherwise, you then had the fantastic services of specialist palliative care. But a bit like breast care many years ago, what was recognised was that there was this care gap provision for those who were newly diagnosed with a non-curative cancer. I'm talking sort of stage 3, stage 4 cancers. They were slipping through the net and weren't being supported. They didn't need specialist palliative care at that stage, but they did need some degree of support. What was also looked at was the longevity and quality for those accepting of intervention. And what Christie's found what Christie's actually found was that people were living longer if they had more intervention. Also, it was about, like everybody else has said this afternoon, the holistic support of those referred to enhanced supportive care and those who were accepting of it. And quicker and more effective symptom control between the interface of enhanced supportive care and specialist palliative care. Now, personally, I've experienced that with patients over the initial period of introducing enhanced supportive care. And a bit like Carolyn was talking about with the communication line with Cornwall Hospices, which is now 10 years old, I can now boast and say that ESC is 10 months old. So yeah, we are the new kid on the block, and I'll tell you more about the team in a moment. But the important thing is, and the word I want to use is that dovetailing of support between enhanced supportive care for those who are newly diagnosed with a non-curative cancer and specialist palliative care and any other service that we will refer to for supportive care. Safety netting and cost effectiveness, really important to make sure that everybody, as much as possible and realistically possible, are supported. And also breaking those negative connotations of the term palliative care with earlier engagement. Liz alluded to the fact earlier about the fact of people who refer to palliative care and are worried because of the term. I can go back even further, and many of you will remember the term Macmillan care. And I can remember the first Macmillan nurse many years ago who wasn't allowed to wear her Macmillan badge for that very, very reason. Well, of course, it's very different today. Apart from the coffee mornings Macmillan put on, they can also perform heart surgery, which when I was a Macmillan nurse, I have to admit, I could never perform. I never did that course, English National Board or otherwise. Forward rather than retrospective planning from all AHPs. And I'll give you some feedback from one of the physiotherapists I referred to in the early stages of ESC. And that person actually stated that to have earlier intervention made such a difference for her patients. And in actual fact, she was working with 2 stage 4 cancer patients she had taken to the gym in order to do cross-training to fundraise for cancer services. So I rest my case, says he, who I'm afraid I will confess hasn't been to the gym for a while, mainly due to COVID, of course. I know I can hear you all saying, but I certainly need to get back out there. Cornwall's demographics, population, as you know, almost 600,000 with a 0.72% increase. Increase in population by almost 51% since 1951, with a decrease in younger groups and an increase in the older groups. 1 in every 2 people will die of cancer, approximately 3,800 cancer cases per year within the NHS Kerno CCG. And if we look at quality outcomes framework, the NHS long-term plan is that 75% of cancers diagnosed by 2028 with a 5-year survival of 55,000 people. So we actually need more input across the board. So the patient's journey, well, there is an initial inquiry from the GP, obviously. GP follows up and the sharing of bad news. Referral to oncology, seen in oncology and treatment plan identified and discussed. And then the referral is either to the site-specific nurse, plus or minus ESC, plus or minus specialist palliative care. And our referrals come through our system at RCHT, where we are based, through the radar system. ESC to assess the patient and re-refer according to patient needs. We are based at Trelisk, and when I talk about we, I'm delighted to say that since the 1st of January, we now have, the ESC team now comprises of both a occupational therapist and a dietitian. And from the 1st of March, we will have our own physiotherapist, and hopefully by the end of March, we will have our own speech and language therapist. We do measurement of standards through referral sources. We enter our data onto all the registers that collect information, such as the Somerset Cancer Register. But most importantly, we are working towards key performance indicators. Now, I know that's often a very sort of long, woolly sort of term, but basically we were funded by NHS England initiative, and therefore we have to perform to key performance indicators to demonstrate exactly how we are improving the quality of a patient's life. And also because the team, the ESC team, with the exception of myself, will have to demonstrate to the trust our worthiness, both financially and quality, so that they will pick up and make our temporary contracts sustainable. Holistic needs assessment has already been mentioned by Wendy, so I won't go through that, bar to say that we work very closely with all the site specifics and the cancer support workers for the holistic needs assessment. So applicability, well, I've split Cornwall into two areas, as you can see here, not because Cornwall is split into two areas for ESC, but it is with regards to level 1 and 2 patients. Okay, so if I go back to the previous slide, when we talk about levels of intervention, we talk about the fact of working with basically levels 1 and 2 dependency, whereas levels 3 and 4 may well be under specialist palliative care. We will still have that interface and dovetailing, and we may still work with those patients. It doesn't mean to say that, you know, here we go, here's specialist palliative care, we're no longer involved with you, but we are working closely to work on that interface so that the patient has that seamless approach through their cancer trajectory towards the end of their life. So the ESC CNS, like I said, I've got a palliative background of over 19 years as a palliative care nurse specialist, and I was one of the country's first non-medical prescribers. We have our occupational therapist who's got extensive rehabilitation background. Our dietitian has, again, an extensive cancer and palliative care background. They are very experienced people, and our physio and our SALT specialists coming to work with us likewise. Watch out, pants outside the trousers will be a very formidable team, I think. Bear with me. So we also liaise with the supportive care teams in the community. We strive not to create a dependency. We are very flexible in our working approach. We work Monday to Friday, 8 to 5. We can be contacted, etc., through the channels. Like I said, most of our referrals will come through our radar system. So where are we going next? Well, initially our cancer groups were lung, CUP, cancer of unknown primaries, brain, upper GI, and that should be HPB. And from the 1st of December, we took on breast patients. So working very closely with Wendy and Louise, and taking on board the breast referrals. And from March the 1st, we should be taking on gynecological stage 3, stage 4 cancer patients. Also, one thing I would say, in addition to the staging, the criteria initially was that the performance status of these individuals would be stage 3/4. However, realistically, when you've got a metastatic cancer patient referred to the ESC team, very often they're a stage 0 or 1. So we're very flexible with actually who we take on to our caseload. I've said about the interface with the site-specific CNSs and the acute palliative care team, and also with the hospice team, and becoming part of their multi-professional cross-county MD. I personally weekly meet with clinical oncologists graduate. You will know him. He is the oncology lead for ESC, whereas I am the nurse lead. We meet with other AHPs to gain their perspective on the interface, bearing in mind that we are the baby service and we are developing. So we're open to suggestions and input, etc. And the review of the past 8 weeks input from the site's specific CNSs to identify their referrals. It's really interesting because a huge part of the work is audit, both collection and collation, and in order to really support and prove the need of the service. Recognition again of patient potential pathway and potential needs. As I've already said, we are an ever-growing and developing service. Leaflet to explain to the patient ESC plus their questionnaire, etc., etc. Okay, and that's it really. Those are the references. I've whizzed through because I know that we're over time, so I'm sorry if it's a very fast presentation, but I just wanted to have the opportunity. Thank you for inviting me to talk today, and also to have that opportunity to say hello to the wider team out there in the community and to say, here we are, watch this space. And thank you very much indeed. Any questions?
Thank you ever so much. I really appreciate it. Siobhan has just said ESC and HNA, both invaluable. Look forward to dovetailing with your team from the hospice setting. And then Katrina has just put in the chat, well done, Mike. So lots of comments coming through, Mike. No specific questions, but I think what we'll also do is be sharing the presentations and all of the opportunities to link all of this together. And hopefully just further support, obviously, all the work through all the connections that you're doing. What an amazing service. Congratulations and thanks so much for sharing your time and all of your experience and all of your learning with us this afternoon. So thank you, everybody. We have actually managed to finish just about 2 minutes past 4, so I'm quite impressed on our first day. I hope you agree that it's been an incredibly informative afternoon, amazing presentations, an awful lot of learning and an awful lot of sharing. So thank you so much. Obviously, Lolly has shared the survey. We'd really appreciate you being able to fill that in for us. And hopefully you can also join us tomorrow when we're talking about planning and keeping well in the community with another list of amazing speakers. So thank you so much for all of your time and effort today.
Thank you. Thank you.